So we're going to move on to the next section of this. And again, as questions come up, please write them down and we'll answer them at the end of this, series of talks here. So ERCP, tools and techniques in 2020. So a 70-year-old man presents with right upper quadrant pain. His labs show elevated liver tests. Abdominal ultrasound reveals a 5mm CBD stone and a 6mm bile duct. ERCP is attempted for stone removal. Despite multiple attempts, biliary cannulation is unable to be achieved. And here's a picture of the ampulla. 40% of you guys perform ERCP. So what would you do next? You're in the procedure, you can't get in. The guy's got a 5mm CBD stone and a small duct, or relatively small duct. Your options are A, abort the procedure, B, try contrast injection, C, needle knife pre-cut sphincterotomy, or D, EOS guided rendezvous. If you don't do ERCP, go through. All right, so 65% would do a needle knife pre-cut sphincterotomy. 24% would do EOS guided rendezvous. It's bold. You can see the duct is not that big. And then a couple people would abort or try contrast injection. Okay. So the next talk I will be giving on biliary cannulation and access. Much of this talk are tips and techniques that I've learned either from going to DDW, reading about it in the literature, or really a lot from my mentors who have taught me how to perform this procedure. All right. So a lot of things I'll be talking about today are things I've heard from Dr. Muthusamy and Dr. Sedarat, who have been my attendings in the past, and I still hear them in the back of my head while I'm doing these procedures, telling me to do this or that. But I think they're a very important piece of advice that I'd like to pass along for those who perform ERCP and may have issues or trouble with certain types of procedures. So my disclosures. So an outline. So before we get into the actual techniques, let's do a quick introduction to ERCP. We'll talk about the top 5 rules that basically I've come up with. Biliary cannulation, advanced cannulation techniques, and then sphincterotomy if you have time. So a quick introduction to ERCP, the top 5 rules. And again, these are things I've gleaned from having attended various talks on this topic. Particularly as a young attending, I wanted to see what was out there on advice for how to do this procedure properly or efficiently. Rule number 1, know your patient, right? Seems pretty self-evident. Know the indication for the procedure, right? Today, in this day and age, ERCP is most often a therapeutic procedure, not a diagnostic. We have such great cross-sectional imaging now that ERCP is rarely done for diagnostic purposes. Know the anatomy, right? If the patient's had surgery in the past, you always get this case where you do the ERCP, you think you get into the bile duct, you're successful, and you only find out afterwards the patient had a Roux-en-Y or a hepatocholangiocarcinoma, and the remainder of the bile duct is somewhere else, right? That you've just cannulated the dead-end stump of the intrapancreatic portion of the bile duct, not really that the patient had some sort of surgery in the past. So make sure you know the anatomy before going in. Make sure you review any imaging, particularly any MRCPs that are very helpful in terms of guiding where you want your guide wires to go, your stents to go. Look at any other previous ERCPs. Look at the cholangiograms that have been performed. So when you go in for this procedure, you have a roadmap for where you're going to go and have a plan, right? What is your plan for the procedure? Is it to do balloon dilation, stent placement, stone removal, and so on? Rule number 2, know your tools and techniques, right? And those of us who do ERCP, there's a lot of different options for a lot of parts of this procedure. So know your devices, the different types of catheters, tomes, and guide wires that are available, different types of balloons different types of dilation devices that are available to you, graduated and balloon dilation. For stone removal, there are a bunch of different techniques, and Dr. Issa will talk about this in a subsequent talk. Balloons, baskets, EHL, holmium laser. Understand your different cannulation techniques and your comfort level with each of these techniques. And understand that there are small advantages to certain devices and techniques depending on the situation. And that's why you want to be familiar with these different tools and techniques so that you have them available to you depending on the situation that arises. All right, and this is just a small sample of the different types of things to consider in terms of tools for ERCP, your catheters, your needle knife, your brush, injection needle potentially, forceps, the different types of wires, balloons, baskets, stents, cholangioscopy. So all things to consider. You want to know what you have in your inventory before you start the procedure. If you have a particular case and you don't have one of these things, you want to talk to your rep or talk to your hospital about getting some of these devices in for your particular procedure. Rule number 3, prevent pancreatitis, right? So this is the big bugaboo of ERCP. This is why I tell patients I would volunteer for an upper endoscopy or a colonoscopy. I would never volunteer for an ERCP because of the risk of pancreatitis. So minimize trauma to the ampulla as much as possible. Try not to inject the pancreatic duct. Give rectal indomethacin, right? It's become an ESGE recommendation that everyone essentially gets rectal indomethacin. I tell my fellows basically, unless they're allergic to indomethacin or they don't have an anus, they're getting rectal indomethacin, right? And pancreatic duct stenting when it's appropriate. Rule number 4, persistence versus insanity. So the definition of insanity is doing the same thing over and over again, but expecting different results, right? And I think in ERCP, it's very tempting to just do the same thing again and again, hoping and praying that one time the wire will magically get into the bile duct, all right? If it's not working, you got to do something different. So be persistent, but don't be insane. Other side right over here is laughing at me. All right. Rule number 5, know when to stop. So safety first, right? Do no harm. Consider a time limit. So if your ERCP is going on for an hour or 2 hours, you got to think about when is enough, and stop the procedure. Is going on for another half an hour going to actually benefit the patient or yourself in terms of getting into the bile duct? Try to mitigate high-risk behaviors. This includes some of the advanced techniques that we'll talk about. And understand your comfort level with some of these advanced techniques, right? Some of you are going to be very facile with the techniques we talk about. Others may not be. But understand your limits before you harm the patient. So again, the 5 rules for ERCP: know your patient, know your tools and techniques, prevent pancreatitis, persistence versus insanity, and then know when to stop. All right. So with that, we'll get into biliary cannulation. And again, most of this, I think those of you guys who do ERCP know this stuff, but I think it's just good to review. The anatomy of the ampulla, it can be a double barrel with a common bile duct and the pancreatic duct. There are 2 separate orifices at the level of the ampulla. Other times, or more often, it's a very short common channel. For biliary cannulation, you want to think about the trajectory of where you want to put your guide wire. Right, so if, my mouse here. So the picture on the left, understand the bile duct is kind of superior to the pancreatic duct. You want to get underneath the ampulla and have an axis where you're shooting up into the bile duct, into the 11 and 12 o'clock position when you're looking at the ampulla. And contrast this with the pancreatic duct, which is more straight on, and so you don't have to be necessarily underneath it as much. It's kind of a straight shot in, and it's between kind of the 1 and 4 o'clock position when looking at the ampulla. And so depending on which duct you want to get into, you want to make sure you orient yourself in the right position for success. So if you look at this picture of the sphincterotomy into an ampulla, it's trying to get into the bile duct, you want to aim in kind of this 11 to 12 o'clock position of the ampulla. So some cannulation tips. 1, observe. So study the papilla, right? Take a minute or 2 to look at the papilla and try to identify the orifice that you're trying to get into. So if you're trying to get into the bile duct, look for the biliary orifice. And taking a minute or 2 to do this may actually save you a lot of time on the back end. So this is a Scandinavian study that was recently published in Gastrointestinal Endoscopy. They tried to classify different types of papillas to determine if they had a bearing on how difficult biliary cannulation was. So they defined the papilla as 4 different types. You have the regular classic type 1, the type 2, which is a small little papilla, like a button papilla. Type 3 is the protruding or pendulous papilla, and type 4 is creased or ridged. And in terms of incidence, they found that more than half the patients in their study had a normal or classic appearing papilla, seen on the left, and then the small 13%, the pendulous 23%, and then this creased was only seen in 8% of patients. And what they found in the study was that depending on what type you had, may have an effect on how tough the cannulation was. They found that types 2 and 3, so again, that type 2 is a small papilla, type 3 being that pendulous papilla, were more difficult than the classic papilla in terms of biliary cannulation. there's not much you can do about it in terms of when you get in the patient, you see the papilla, you have to deal with what you deal with. But this may help you figure out, how difficult is this going in, kind of mentally prepare yourself for the procedure. And again, I'm sure plenty of you guys have done this before, use glucagon as needed if there's a lot of peristalsis in the duodenum and you're having a hard time getting a stable look at the papilla. This is a tip that Dr. Muthusamy tells us all the time, axis, 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 right? So you want to align the catheter with the desired duct. So if you're trying to get into the bile duct, you want to aim at the upper 11 o'clock position. Oftentimes, as you see in the picture here, you may need to bow the sphincterotome in order to get the axis kind of up anteriorly or superiorly into the bile duct. If you're looking to get into the pancreatic duct, you kind of aim in that 1 to 4 o'clock position, and you can take a much straighter approach. And again, here in this picture, the catheter or the sphincterotome is not bowed getting into the pancreatic duct. But it's all about axis, right? If you're not lined up with the papilla to do this procedure, you're really just hoping and praying that you're going to get in with luck. Attain optimum orientation of the catheter relative to the papilla. You may have to groom the catheter or rotate the sphincterotome if needed to get into that position. Stop pushing. Another axiom from one of my attendings. Don't jam the catheter into the papilla, right? So I think it's very tempting when you get engaged into the papilla to just shove the catheter in further. But what often happens is that you can accordion the distal bile duct. You're unable to deeply cannulate. So you may actually be in the bile duct, but the wire won't go up because you're jamming the catheter against the back wall of the bile duct. And then you can lead to submucosal injection if you decide to do a contrast injection there to try to delineate the bile duct. So oftentimes the tip that I was given was instead of pushing out the catheter, kind of big wheeled towards you, kind of ride up into the bile duct. So in terms of trajectory, you're kind of going up superiorly into the bile duct rather than pushing out the catheter. Change something, right? If it's not working, try different guide wires, right? There's straight and angled guide wires out there. There are different size guide wires that you can attempt to use. You may want to change the type of tome or catheter you're using. You can go from long wire to short wire, and sometimes even changing the assistant, right? It's hard to change the doctor, but sometimes if you're having a bad day with a certain assistant, you may ask for one of your lead techs to come in the room and help you out. We've certainly had cases where you can't get in with an inexperienced tech. I asked for the more experienced tech to come in, and within a minute or two, we're in the bile duct, right? It's simple as changing the tech in certain cases. And then try again another day, right? I think we have a lot of pride. We don't want to fail ERCP. You want to come out of the procedure and tell the patient, the family member, we didn't get into the bile duct, but it's something to consider. All right, so know when to stop. Again, that's rule number 5. But repeating attempts at cannulation can lead to papillary edema. Submucosal injection can obliterate the papillary anatomy. Or you can even create a false track. And when this happens, spending more time in there isn't really going to help, right? You're just going to make things worse. If you think the edema that you're causing from biliary cannulation is difficult, it's only going to get worse if you spend more and more time in there. But typically resolves in 24 to 48 hours. You can try again in a couple of days. All right, so there are my cannulation tips. We're going to move to advanced biliary cannulation techniques, some of which, some of you may be familiar with some of these. Some of you guys are very good at this. Others may feel very uncomfortable with some of these techniques. But let's just go over a few of them. So there's lots of different advanced cannulation techniques. Contrast injection, double wire, a wire over a pancreatic duct stent, pre-cut sphincterotomy, the various forms, freehand or over a stent, transpancreatic septotomy, fistulotomy, or even EUS-guided rendezvous. I'm not going to go over all these today. Maybe some more of the common techniques that you can use. So this is a case where we're trying to get into the bile duct. There's a distal biliary stricture. The wire keeps, you feel like you're in the right position, but the wire is not going up into the bile duct. So you see a little contrast. You can see the contrast in the bile duct. And now you're kind of using the fluoro image to help guide where to put your catheter. And with a little bit of work, there the wire goes up. I don't know what happened there. It froze for a second. We'll move on. So this is a double wire technique. And this is a technique that I've certainly used plenty of times where I try to get into the bile duct, the wire goes into the pancreatic duct. Sometimes you take that pancreatic duct wire out because you want to get in the pancreas, and then you spend another hour trying to get in the bile duct, right? So other times you leave the pancreatic duct wire in place, you aim at 11 o'clock, you aim over the pancreatic duct wire, again, head in that 11 to 12 o'clock position. It's using a different axis than the wire is in, because the wire's in the pancreatic duct. The wire is holding down or blocking off the pancreatic duct, and you're going to aim above it at 11 o'clock. And hopefully the wire will go into the bile duct. So it's a little bit of struggle here. Again, so a little bit of different axis than the way the pancreatic duct wire is going. And with a little bit of work, here goes into the bile duct. Right. Okay. So this is needle knife sphincterotomy over a stent. So now you have a stent into the pancreatic duct. Use a needle knife. And basically, again, another thing I was taught was just you cut like you're cutting an onion, layer at a time, right? So you don't have to take the whole needle knife out. Take out a little bit of the needle knife and start cutting up, typically from the papilla up and away into the axis of the bile duct, so into the 11 o'clock position. So cut, kind of up into the left, and just repeat it over and over again. Sometimes you get a nice spill of bile. Other times, depending on your comfort level, you may want to stop, try cannulating again. If you don't get in, take the needle knife out, cut a little bit more, and keep working your way in. And again, I think it's when you watch these videos, you go to DDW, these people always show these impressive videos of how easy it is. I think in real life, sometimes it can be a bit scary. It starts really easy. You think it looks like a great, nice intraduodenal segment of the bile duct. You start cutting, and all of a sudden you start losing your planes. And you have to know when to stop, right? When you feel uncomfortable cutting anymore. And other times where you feel like, I think there's still a little bit more space to go. I think I can cut a little bit deeper and work your way in. So I think it takes a little bit of practice and familiarity with this technique before you can start using this with any regularity. Here again is a wire over the PD stent. So you're trying to cannulate kind of using a double wire technique with the PD stent in place. So you struggle for a while. And despite trying this technique for a period of time, it doesn't work. And so now we go to a needle knife. And now that the stent is protecting the pancreatic duct, you can try cutting over it. Again, here's cutting, here's a pre-cut. And after you cut for a period of time, it may not be obvious, right? So again, you may cut for a period of time and feel like, I'm going to try biliary cannulation and take the catheter out, the tome and wire, and reattempt biliary cannulation. And it got so frustrating, we took the stent out. It was difficult to cannulate over the PD stent. And we got in after the stent was removed, right? After needle knife was performed. This is a fistulotomy. This only works if you have a nice, big, bulbous intraduodenal segment of the bile duct. And rather than cutting from the ampulla or the papilla, you can just cut the papilla itself. And again, this is where you have to be careful with the planes, right? So in the beginning, it looks like it's nice and juicy. We just go in there, we're going to cut. And if you're watching the videos, you expect this nice spillage of bile, and we should be able to get in the bile duct really easily. We start cutting, and you realize the planes are not always easy to identify. And you say, well, where am I now? Should I cut deeper? Should I cut from above or below? So at one point, this cannulates actually the pancreatic duct. You can see it's a little bit lower. PD stent's placed to protect the pancreatic duct. And then the bile duct is found somewhere in the midst of this fistulotomy, right? Okay. I'm going to skip this for now. I'll end with this sphincterotomy. So how much should I cut? So this is obviously sphincterotomy, and many has performed this for stone removal. As you can see us cutting to the transverse fold there, right? And the point is you should cut large enough to get the job done, right? If you're just doing this to pass a cholangioscope in, you don't need to make a big cut. If you're trying to get a big stone out, then you need a bigger incision to get the large stone out. And you can safe to cut to the transverse fold on the superior aspect of the ampulla. So again, I think many of us make very small incisions because we're afraid about how big an opening we can make. But again, you can cut safely to that transverse fold. This is my last video. So again, cutting a little bit more. And now we're going to get this stone out of the bile duct. And here's that big stone, right? So I'm going to make a cut big enough for the stone to be removed safely. And that's very satisfying. And then lastly, consider a sphincteroplasty or balloon dilation. I'm not going to show this video because I know Dr. Issa will discuss this in his talk. So conclusions, remember the top 5 rules of ERCP. Know your patient, know your tools and techniques, prevent pancreatitis, persistence versus insanity, and know when to stop. Study the anatomy of the papilla. Understand the trajectory of the catheter and its contact point on the papilla are crucial for successful biliary cannulation. Do not jam the catheter into the papilla. Familiarize yourself with advanced cannulation techniques, and sphincterotomy should be large enough to get the job done. Thank you. All right, so we'll move on here. A new case, a 40-year-old woman with a history of cholecystectomy presents with right upper quadrant abdominal pain. Labs reveal elevated liver tests. Abdominal ultrasound shows a large 2-centimeter stone in the common bile duct. ERCP is performed to attempt stone removal. Here is your cholangiogram. And you can see this big, giant filling defect in the bile duct measuring 19 millimeters across. To the audience, what would you do next? A, place a biliary stent. B, balloon sphincteroplasty. C, mechanical lithotripsy using a basket. D, cholangioscopy with EHL or laser. Or E, get out and do extracorporeal shockwave lithotripsy to break up the stone. All right, so most will do mechanical lithotripsy with a basket or cholangioscopy with EHL or laser. All right, so to talk more about this, we have Dr. Danny Issa. We talk about removal of the difficult CBD stone. You can do it.
Thank you very much, Dr. Kim, and thank you everybody for being here today. We're going to talk about removal of difficult CBD stones. So ERCP has been the treatment of choice for CBD stones for more than 30 years. However, some stones tend to be difficult, or sometimes we call them recalcitrant. And that is defined as the inability to remove those stones using your standard ERCP with biliary sphincterotomy. So what makes a stone difficult? Well, there are a lot of factors that can play a role into that. So as we said, size of the stone is important, the shape of the stone, the location of the stones. Intrahepatic duct stones are usually difficult. Cystic duct stones are always hard to reach and remove for sure. Sometimes you have a distal stricture with the stone impacted proximal to the stricture, which makes it difficult, and lack of tools that you might need to get this done. The good news is we have multiple factors and multiple modalities to tackle difficult stones, and that's what we will talk about for over the next few slides. So first we will start with mechanical lithotripsy. Baskets are commonly used for stones removal. There are multiple baskets commercially available for clinical use. The one you see on your left hand there is the trapezoid basket by Boston Scientific. Basically it comes in 4 different sizes from 1.5 till 3 centimeters, the opening of the basket. It can be used over over short or long wire systems, and it really has a nice flexible catheter with good pushability. The basket on your right hand is basically comes as either 4 or 8 wires, called Flower Basket by Olympus. This one also has 2 sizes and can be used over short wire, and it has an injection port that helps you to inject contrast during the procedure. The question is, when do you consider using basket? If you have a non-dilated duct with a free-floating stone per se, like here, I think most likely you'll be successful using balloon sweep. However, the problem with the balloon, if your duct is dilated, the balloon can simply squeeze between the stone and the wall of the duct. And another example is when you have either a dilated duct or you have multiple stones inside the duct, a balloon sweep is not going to be successful most of the times. And in this situation, basket will be very helpful. Also, I want to remind you, in this situation, if you're using basket, I would start really distally in the lower bile duct and start sweeping those stones first, and then go up gradually, so not to have these stones impacted in the common bile duct. Complications of mechanical lithotripsy or baskets, basically bleeding and pancreatitis can happen. I think the fear of basket impaction and wire fracture is a little bit overrated. It's usually around 4% in the literature, and most of the times this can be salvaged by using emergency lithotripsy, although none of us really likes to see that device being used for basket retrieval. Next, we're going to talk about balloon dilation of the papilla, which is another way to help with stone extraction. And what we do is also called sphincteroplasty. And what you do is you use usually CRE balloon, and you can they use different sizes from 12 to 20 millimeters, and it usually helps with stones which are up to 18 millimeters. You need to have 2 things to do this: intact papilla, and you need to have had a sphincterotomy done. Having said that, doing primary balloon dilation of the papilla is not usually recommended, because it might be associated with a higher risk of severe cholangitis, severe complications, and especially pancreatitis. As a matter of fact, a randomized trial looked at 230 patients and randomized patients to receiving either biliary sphincterotomy or primary balloon dilation of the papilla without sphincterotomy, and there was increased risk of severe pancreatitis in the group that received primary balloon dilation, and 2 of those patients actually died from pancreatitis-related complications. So in the United States, the ASGE recommends doing sphincterotomy first rather than doing primary balloon dilation for stone extractions. So usually it's successful, and really a lot of the times, and we will talk about some challenges. Sphincterotomy can be complete or partial, and complications include pancreatitis and bleeding. It has been looked at, the size of the balloon does not correlate with the risk of pancreatitis. So if you're planning to do balloon dilation of the papilla for stone extraction, just keep in mind the 3 important rules. First of all, try to taper the balloon to the size of the duct. So if your duct is 10 millimeters, don't go over that with the balloon dilation. Just stay around that. Don't go to 14. You can certainly have perforation from that. The second rule, make sure you don't have a stone impacted between the balloon and the wall of the duct, because also that can get you in trouble. And the third rule is, if you have a stricture and the distal bile duct, balloon dilation probably is not going to be effective in that situation. So mechanical lithotripsy is usually effective, but there are a few limitations, which are impacted stone, non-dilated duct, intrahepatic stones, and very large stones. So this is an example back to what Dr. Kim talked about, going back to the basics. Sometimes if you have an impacted stone, like this patient at the papilla, and all you need is really to get access. So in this case, we did pre-cut with a needle knife to get biliary access, and then as soon as you got in, the stone came out really nicely, so you really did not do anything else. Recently, there has been more talk about stone to duct ratio, and basically what it means is the stone size to the common bile duct size. And this really nice paper randomized patients to either balloon dilation or a laser, published last month at CGH. And they define stone to duct ratio if it's more than 1, meaning that if the stone size is bigger than the duct size, balloon dilation is not going to be as effective. So it's good. It's something good to keep in mind. So if mechanical lithotripsy is not effective, we can move to more powerful tools. And luckily, we have a few of them. So EHL, or electrohydraulic lithotripsy, basically what this does is it produces intraductal shock waves. And you require a fluid medium, a lot of irrigation to make this work. And it produces a spark that leads to a stone fragmentation. You certainly need to use direct cholangioscopy guidance to do EHL. It's quite effective, high 90s. You can achieve either complete clearance or partial clearance and use balloon sweep or basket to complete the clearance at the same session or later session. Laser lithotripsy is just another way of doing it. Some people think it's a little bit more effective. It's very comparable according to a lot of studies. It also produces intraductal shock wave. The difference is this shock wave is pulsed compared to a spark as in the EHL, and the success rate is up in the high 90s as well. Complications of laser or EHL lithotripsy are basically, around 3 to 10% or 12%, and most of them are related to cholangitis. So always remember when you do either a direct cholangioscopy or laser or EHL to give your patients a course of 5 days of antibiotics to cover them prophylactically from any infections. So this is a video of laser lithotripsy for a patient with a large stone. So what you need to have a lot of irrigation to visualize this stone very nicely. The 365 micron holmium laser probe is advanced through the channel, and it comes at 6 o'clock, as you see there. Ideally, you want this probe to be 2 millimeters away from the stone to work the best. So the way to achieve that is by touching the stone with the probe and then pulling the probe a little bit, because if you're on the stone, you will have more of a burning effect, but if you're 2 millimeters away, you'll have the fragmentation effect that you need. And after you do that, we usually use 10 watts, and mostly it's successful or effective, and if it doesn't work, we can go up to 12 watts energy, and that will help fragmenting the stone. After that, we use the balloon to sweep those fragmentations out and clear the duct. Now, if you don't have access to laser or EHL and you want to take care of the problem right away, you can place a plastic stent in the bile duct, and it has been looked at, has been studied. It's a nice temporary measure to take care of the problem, but it should not be a first step. And preferably place a double pigtail plastic stent rather a straight plastic stent. I think it just helps to prevent migration a little bit more. And according to studies, it certainly helps with subsequent stone clearance in the future. Now, metal stents can also be used, but for lithotripsy. But this has been studied, and the main question is stenting alone good enough for lithotripsy? And the answer actually is no. There is a randomized study looked at this, and there were more complications in patients who underwent metal stent placement for lithotripsy compared to the standard, and most of those complications were related to the stent itself. So if you want like a quick fix, if you're doing the patient in like suboptimal circumstances, or the patient has cholangitis, place a plastic stent and just get out of there and plan the next step from there. There are other situations that we don't have time to get to, but always think about your patient's anatomy. So altered anatomy cases are frankly challenging. Usually Pilroth 2 or post-Whipple patients, we can get to the bile ducts, and those patients most of the times. But patients with gastric bypass anatomy, the rule tend to be very long, and in those situations we cannot easily get there. I think we usually have one of 3 options. We either do lab-assisted ERCP, or we do a procedure called EDGE, which is creating a stent between, or fistula between the pouch of the old stomach and the new stomach pouch, or we can do usually double balloon assisted ERCP, but those patients are the most challenging. You can also have a patient with intrahepatic stones, which are very, very refractory, and bile cast syndrome is another stone-related syndrome. And recently there was a nice image at New England Journal actually of a explanted liver with bile cast syndrome. It's really nice to look at. Those patients tend to be very challenging, and sometimes they need liver transplant. And in summary, this is my approach for difficult CBD stones. Look at the stone to duct ratio. If the stone to duct ratio is less than 1, you can try balloon dilation of the papilla after you perform sphincterotomy, and you can try mechanical lithotripsy, and most of the times you'll be successful. If the stone to duct ratio is more than 1, probably you will need either EHL or laser, and you might have to put stent if you don't have those. If you have an impacted stone, I think most of the times you will need EHL. If you don't have that, place a stent. And also remember, we have other options like extracorporeal shockwave or ISWL that can help to decrease the size of the stone and fragment the stone a little bit. For distal CBD strictures, balloon dilation is not going to be successful. You can try mechanical lithotripsy with other ways, or you can try EHL or stent placement. And for intrahepatic stones, you probably will need EHL laser, or sometimes you will need surgery or percutaneous options. So in summary, ERCP is the standard of care and usually successful. However, 10 to 15% of CBD stones tend to be difficult. We have multiple modalities, and endoscopic options are highly successful. And even for recalcitrant stones, you can get it done. Thank you.
All right, so the last but not least speaker of our session here will be Dr. Thaker. And he'll be talking about bile duct stents, not always easy peasy.
Okay. Thank you very much. I know we're running short on time, so I will be mindful of that. And today I want to talk about the decision about stenting. It can be challenging. It's somewhat of a lonely decision. You may have just gotten through the big steps of cannulation, performing your sphincterotomy. Maybe you just got a diagnosis, and now it's a decision of what type of stent to place. Are you going to go with a plastic, a metal, what type of metal, what inventory you might have? And I'm going to review some of the key considerations. I've given some of the data in your syllabus, so I'll probably run through that somewhat more quickly. But as you'll see, it doesn't have to be as stressful of a decision as it seemed to be in the beginning. So what are the key considerations for stent selection? I think most important is your determination of its removability. So partially and uncovered metal stents should not be placed if there's a reasonable chance that you're going to need to remove that. And so some of those considerations would be tissue diagnosis. And for those of you that were at my video forum yesterday, we saw a case of an uncovered metal stent placed in a patient who was thought to have pancreas cancer, and it turned out to be autoimmune pancreatitis, and 12 years later it took to get the stent removed. And then we also heard from Dr. DiNorcia that in anticipation of someone that may need surgical transplant, or we'll talk about briefly patients that might need a Whipple procedure, it really you should give pause before putting one of these in. Otherwise, we think about migration rates, stent patency, cystic duct obstruction, and the risk of cholecystitis, as well as the costs. And so I'm going to go through some of the advantages and disadvantages, some of the key principles. But as we'll see, some of them are in principle true, but where I put an asterisk, like we have below, the data may not necessarily support it. So what are the advantages of plastic stents? The removability, they're very easy to remove. They tend to be inexpensive, but there's an asterisk there, so we'll talk about the cost benefits. And they are quite effective for initial drainage. The disadvantages are the lower and variable patency, and in studies, the ranges have been reported from 60 to 200 days. In fact, in a study performed at our own center, it was down to 49 days versus over 270 days for metal stents. For covered metal stents, and SEMS for at the top where you see the abbreviation is self-expanding metal stent. So the advantages of them are the removability, and the reason is that you avoid tumor ingrowth because there's some kind of polyurethane or other covering that prevents the tissue, whether it's hyperplastic tissue or malignant tissue, from growing into it. The disadvantage of covered stents are the migration rates, so reported up to 6 to 8% versus 1 to 2% for uncovered stents because you're taking advantage of that tissue ingrowth. For hilar and proximal strictures, you potentially will jail off the ducts that are on the contralateral side. So in general, we do not place covered metal stents up at the proximal strictures. We'll talk about the cholecystitis rates because of, again, blocking off the cystic duct obstruction. The covered stents are more expensive than uncovered stents and plastic stents, and then the covering may induce sludge formation and reduce your patency in some cases. Now, one of the ways that migration rates can be mitigated are by avoiding sphincterotomy. And there was an initial belief that sphincterotomy could reduce the rates of pancreatitis. However, in the studies, this does not seem to be true. And so there does not seem to be a pancreatitis advantage unless there's a particularly long common channel that Dr. Kim had mentioned, but you do still have the rates of post-sphincterotomy bleeding. And so we always talk about, do we need a sphincterotomy before metal stent placement? And the answer is no. For uncovered metal stents, it's kind of the converse, the low migration rates. They can be used throughout the biliary tree, and they can be used because if your gallbladder is in place to reduce the rates of cholecystitis. But again, as we saw yesterday, the removability is very difficult, though not necessarily impossible. There's higher rates of ingrowth, and again, the stents are more expensive than plastic stents. And so we will, again, highlight if there is not a tissue diagnosis or some type of likelihood that you may need to remove it, these should be avoided. So now let's look at some of the head-to-head comparisons. So for unresectable obstruction, so patients with metastatic pancreas cancer, for example, it's kind of been over and over been shown that metal stents have longer patency in meta-analysis, over 4 months longer patency without difference in survival or mortality. And the metal stents also have a lower rates of complications of various sorts compared to plastic stents. And then to highlight one of these studies in RCT, this is where the cost, there's that asterisk right there. Sure, in that one case, the plastic stent's going to be cheaper than the metal stent, but when you look at the trade-offs, which are having to bring the patient back for stent exchanges, the lower patency, the hospitalizations, et cetera, the total cost overall at looking 1 year out did not differ whether you looked at patients that only survived 3 months, patients that had metastatic disease at the time you place a stent, or even at 1 year out. And so the cost difference doesn't seem to be as important when you take the whole kind of clinical course of the patient in mind. Now, for patients that are undergoing neoadjuvant therapy before potential resection of their pancreas cancer, it's also been shown that metal stents are superior to plastic stents in terms of the rates of recurrent obstruction. You can see the rates are quite different in meta-analyses and also in head-to-head analysis. One retrospective study from our own institution, it was multi-center, showed only a 49-day median patency for plastic stents and a 45% rate of hospitalization. And so it's pretty well established now for patients undergoing neoadjuvant chemotherapy or radiation or a combination of two before something like a Whipple procedure should probably have a plastic stent exchanged out to a metal stent. Perioperative outcomes are also similar, and the big concern is that if there's a metal stent, how is it going to affect the surgical kind of operation? And some surgeons may actually prefer plastic stents preoperatively, but it's been shown repeatedly in the surgical literature that surgery, and specifically discussing Whipple, can be performed with metal stents. There was a concern that there would be an inflammatory reaction that would affect the anastomosis and therefore lead to later complications, but it does not seem to be borne out in the data. And again, metal stents have lower rates of obstruction, cholangitis, and hospitalization in those patients undergoing chemotherapy before they await their surgery. So one potential tip, if there's a patient that you have that has greater than 3 to 6 month life expectancy, consider a metal stent. The costs don't seem to be as important of a difference when you're looking out for three months up to a year. And also, potentially, if someone's resectable, so they're getting neoadjuvant chemotherapy, really a metal stent is the way to go. And so the only time in terms of a patient that may be preoperative, I think that they have a pancreas cancer that may be immediately resectable, that may be a case where I will place a plastic stent because I know that our pancreas team will have them into their clinic within a week and then be planning their operation immediately. So now we'll turn solely to metal stents, and there's 3 different types: uncovered, there's partially covered where only the center portion of the stent has some kind of covering, and then there's fully covered stents. Now, with all of the data that I present here, you have to take it a little bit with a grain of salt because not all uncovered or fully covered stents are created equal, depending on your brand, depending on what your availability at your institution is. There's a lot of heterogeneity. But in general, there have been 3 meta-analyses looking at the question of uncovered versus just fully covered stents. An older one showed a longer patency for fully covered stents versus uncovered stents. And the idea is that coating that's on the fully covered stent prevents ingrowth into the tumors, into the lumen of the stent. However, 2 meta-analyses since then showed no difference in patency. Both of these earlier meta-analyses also showed no difference in cholecystitis or pancreatitis. And so there's that second asterisk where if you're worried about blocking off the cystic duct by using a covered stent, that does not seem to be borne out in the data. The more recent meta-analysis slightly different methodology, but they also found no difference in overall patency or adverse events of uncovered versus covered stents. And why? Well, fully covered stents did have a higher rate of migration, of sludge formation inside the lumen, and overgrowth, which is kind of tissue growing over the ends of the stent. However, that was kind of balanced out by a lower rate of ingrowth, which happened to be the problem with uncovered stents. So essentially, you're trading sludge formation and overgrowth for ingrowth in your stent choice. And on meta-analyses, when you kind of pool the data, it doesn't seem to make a difference in long-term patency for these stents. And so, and then in terms of cholecystitis, the rates have been reported up to 10%. In one kind of larger study, 457 patients, covered metal stents up to 8% rate versus 1.2% of uncovered metal stents. So it's not zero even for uncovered stents. But again, in 3 meta-analyses, there did not seem to be a difference in cholecystitis rates between covered and uncovered stents. And the same goes true for pancreatitis. And so in general, if you're worried about this, you have a few options. You could try shorter stents that will land below the cystic duct. You could also try to identify where the cystic duct is and make your consideration. But I don't think that you can be faulted for picking a covered or uncovered stent just because of a worry for cholecystitis. And really, as I'll summarize, it's other considerations that should be more important. Hilar strictures have been discussed already, but there's variable conclusions about the best strategy. If someone may be undergoing some kind of surgical management, it really is mandatory to stick to plastic stents. However, metal stents have been shown to have a longer patency, lower rates of intervention. However, the data is usually of low quality and still somewhat evolving. Bilateral drainage is more difficult and has higher clinical success rates, but as Dr. Keswani showed us earlier, there's a lot of considerations in kind of deciding what to do here. There's a few proponents of doing bilateral metal stenting in patients that are definitely not surgical candidates, and it's technically challenging. Reintervention is even more challenging. And then there's also kind of debates on whether side by side or stent and stent. I think this is an area that's unresolved. But for those kind of wondering what is kind of a stent and stent, you place one stent, you get the wire through to the other side, and then you place another stent through it. And this is something that for patients that I think our practice, we do this sometimes, but it's in patients that have unresectable disease that keep coming back in with some kind of complication from plastic stents. And so to conclude, the key points are avoid placing any type of uncovered stent before tissue diagnosis because, as Dr. Muthusamy showed us, up to 20 to 30% of the time, a stricture that you may think may be malignant may end up being benign. And you can always come back and replace it if it ends up being not true. The cholecystitis data is mixed, so choose the stent that's otherwise most appropriate or choose a very short stent. Fully covered is fine. And sphincterotomy does not appear to reduce pancreatitis and may actually allow migration, and also you have the risk of post-sphincterotomy bleed, so it's not mandatory. And then in terms of stent selection, really more than all of the considerations here are what's going on with the patient in front of you. So if you have an extrinsic compression, that may be a patient I choose an uncovered metal stent because I'm not going to have too much ingrowth. And then for Hilar strictures, again, you have to go with uncovered stents. And then finally, with this whole talk, all of these principles are maybe true kind of theoretically, but with new stents, some of these things are going to start overlapping. There's fenestrations in covered stents. There may be anti-migration features in covered stents. There may be valves to prevent cholangitis, and there may be new covering materials that I think that this area is going to continue to evolve. But I think overall, there does not need to be as much anxiety as I originally had about choice of stent selection. Thank you.
All right, I just want to thank all the speakers here for this early session. This is going to conclude our session. If you have any questions, please come up and talk to us afterwards during this break. We're going to break till 10:30, so come back here for the next section on I think, IBS.